All right, everyone. Cello, let's begin. Today, we are tackling a system, and I promise you, you will see it in action every single day of your clinical life. From the OPD to the ICU, it's everywhere. It's the body's big boss of blood pressure, the renin-angiotensin system, or what we call RAS. And listen, this isn't just for passing your exams, okay? Really understanding this, that's what's going to make you a good doctor.
Okay, so what's our game plan? First, we'll figure out what sets off the body's BP alarm. Then, we're going to trace the powerful chain reaction that follows. After that, a little backstory on a molecule called prorenin. It's quite interesting. Then, we'll see the two different faces of the main player, angiotensin II. And finally, we'll see how this life-saving system can turn into our enemy. Simple enough? Let's go.
All right, first up, the body's BP alarm. So what kicks it all off? You know, every system in our body needs a trigger, right? A kind of on switch. So let's find out what this switch is.
So let me ask you this. What do you think is your body's emergency alarm for low blood pressure? Just imagine, your body is this incredibly complex machine. There has to be a watchman somewhere, right? A guard, ready to ring the bell the moment the pressure starts to drop. The real question is, who is this guard, and where do we find it?
And the answer is, it's our kidneys. To be more specific, it's a very special group of cells inside the kidneys called the juxtaglomerular cells, the JG cells. These cells are our watchmen, and they are always on alert. They spring into action the moment they sense any trouble. Things like low salt levels, a decrease in blood volume, an actual fall in blood pressure, or even if the blood flow to the kidney itself is reduced, what we call renal ischemia.
Okay, so the alarm bell is ringing. The watchman has sounded the alert. What happens next? Well, what follows is a really beautiful and powerful chain reaction. It's a biochemical cascade. You could think of it like a line of dominoes. You push the first one, and it sets off this whole series of events. It's elegant and incredibly potent.
Now, in this whole drama, there are three main characters you need to know. First, you have the source material, a protein called angiotensinogen. This then gets converted into an intermediate player, angiotensin I. And finally, this angiotensin I is transformed into the main man, the real powerhouse, angiotensin II. He's the one who does all the important work.
So, how does this whole domino rally start? It's simple. Our watchmen, the JG cells in the kidney, they release an enzyme called renin into the blood. Now, renin goes hunting for that source protein, angiotensinogen, which is just floating around in the plasma. Renin finds it and, snip, it cuts it to create the inactive angiotensin I. This is the first, most critical domino to fall.
Okay, but here's the thing. Angiotensin I by itself, well, it's a bit lazy. It's not very powerful. It needs a real kick to get activated. So as it's flowing through your blood, especially when it passes through the lungs, it meets another enzyme, a very, very famous one, angiotensin-converting enzyme. You all know it as ACE. And what ACE does is it transforms this lazy angiotensin I into the superpotent, superactive angiotensin II. Please remember the name ACE. You are going to be prescribing drugs that block this enzyme for the rest of your careers.
All right, now before we see what this powerful angiotensin II actually does, let's take a small but very fascinating detour. We've been talking about renin, right? But where does renin itself come from? Well, it starts its life as an inactive molecule called prorenin. And this prorenin, it has a few secrets of its own.
You can think of prorenin as basically sleeping renin. But the really crazy part is this. In your blood, the concentration of this sleeping prorenin is 5 to 10 times higher than the active renin. Now that's a huge amount, isn't it? It suggests that it's probably not just sitting there waiting. And you'd be right. It can actually be woken up in two very different ways.
So have a look here. These are the two paths. On the left side, we have the enzymatic path. What happens here is another enzyme comes along with a pair of scissors and snip, it permanently cuts off a piece of prorenin to create active renin. It's an irreversible change. But on the right, we have a more subtle, non-enzymatic path. Here, the prorenin simply binds to a special receptor. This binding action makes it unfold and become active, but only temporarily. The moment it detaches, it goes back to sleep. So this one is completely reversible. See the difference?
And these diagrams show it perfectly. Look at diagram A. That's the permanent cut, like using scissors. That piece is gone forever. Now look at diagram B. Here, the prorenin is just docking onto its receptor, the PRR. This binding action alone changes its shape and makes it active, but it's temporary. It's like A is tearing a page out of a book,
while B is just opening the book to read a page. You can always close it again.
Okay, detour over. Let's get back to the main story. We have successfully made our super powerful angiotensin II. So, what does it do? And crucially, how does that pro-renin receptor we just discussed fit into all of this? Because this is where it gets really important. That receptor can actually cause damage in two distinct ways.
This pro-renin receptor, or PR, is like a master switch. You can see here, when prorenin or renin binds to it, it can go down two different roads. On one side, you have the angiotensin II dependent pathway. This is the classic one we all learn about. But on the other side, it can also trigger signals directly inside the cell, a pathway that is completely independent of angiotensin II. And notice, both of these paths ultimately lead to the same bad outcome at the bottom, damaging cellular changes.
So let's look at the first path, the classic angiotensin II dependent pathway. This is the textbook one. Renin binds to the PRR on a cell surface. This binding turbocharges its activity, causing it to churn out a lot of angiotensin I. Then ACE comes and converts it to angiotensin II. Finally, this Ang2 acts on the tissues, causing problems like inflammation and harmful cell growth. Simple enough?
But here's the critical insight from modern medicine. Pay attention. The receptor itself is a signaling molecule. When prorenin binds, the PRR can directly switch on pathways inside the cell, like MAP kinase and JAK-STAT, without making any angiotensin II at all. It's a shortcut, a direct route to the same damage like fibrosis and abnormal cell growth. Understanding this independent pathway is absolutely key to understanding why some of our newer drugs work the way they do.
And just to give you a sense of its raw power, here's a fact to keep in your mind always. If you inject angiotensin II intravenously, it is a far more potent vasoconstrictor, a pressor agent, than even noradrenaline. That is the sheer force we are dealing with here. It's incredibly powerful.
So, a system this powerful is fantastic for saving your life when your blood pressure crashes. That's its physiological role, that's its job. But what happens when this emergency system is switched on all the time, chronically? Well, that is when physiology becomes pathology. That's when the good guy turns bad. So what are the consequences when RAS is chronically overworked? It's a disaster. It's a list of all the major diseases you will manage in your wards. It relentlessly thickens blood vessels and the heart muscle. That's hypertrophy. It drives harmful scarring after a heart attack. It pushes patients into congestive heart failure. And, very importantly for us in India, it's a major driver of diabetic kidney disease, nephropathy, and eye disease, retinopathy. This is the devastating end organ damage you'll be fighting against every day. So please, remember this dual nature. The renin-angiotensin system is your savior in an emergency. But when it's chronically active, it becomes a destructive force that slowly, over time, damages all your vital organs. It is both a friend and a foe.
And this brings us to the most important clinical question of all. If this system is so powerful and so destructive when it's overactive, how do we fight back? How can we block it with medicines? That is the crucial topic we will tackle in our next session. Thank you for joining me.